Hi, everyone. Thank you for joining us for our AI Talks, a Patrick J. McGovern Foundation live stream series that's engaging the civil society champions who are representing our human interests and aspirations in an AI-enabled world. Today, we have a very special guest who's not only a trailblazer in digital and AI-powered health, but he's also a true advocate for health equity in rural regions, both in India and by example around the world. He merges a commitment to care that prioritizes human dignity with a belief in the power of data to support community health workers and improve health outcomes on the ground. It's my pleasure to introduce Dr. Rushith, who's the CEO and co-founder of Khushi Baby. He's also a first-year pediatric intensive care fellow at Yale University. He completed his residency in internal medicine and pediatrics at Yale. He attended medical school at Harvard and public health training at Yale. He now leads a team of 120 members at Khushi Baby, which provides digital health expertise to some of the world's largest public health departments in India. Rushith, thank you for being here today.
Thanks, Yolanda, for having me.
Awesome. And for those of you who don't know me, my name is Yolanda Baci-Ludovico, and I'm a storytelling and advocacy lead here at the Patrick J. McGovern Foundation. I'm a policy expert by training, a human rights advocate, writer, and AI for Good enthusiast, who's committed to sharing stories of hope in which AI is used to help solve global challenges and shape a better future for everyone. So let's dive into our topic for today. Rushith, I think across sort of the global health landscape, we're seeing in real time the growing potential of digital health technologies and AI. We're seeing sort of health systems using AI to drive the collection of data that informs better care. We're seeing health workers using AI products directly to connect across different health verticals and ensure better health outcomes for patients. And many are leading these innovations to scale, much like Khushi Baby, who has actually led your innovation to scale across 3 states in India, which is really incredible. So tell us more about Khushi Baby's unique mission and how your journey with digital health began.
Yeah, absolutely. So at Khushi Baby, we're working to deeply strengthen community health systems. We believe that the path to strengthening these community health systems will require both a combination of technology, big data, but also close partnerships on the ground. And our path actually started almost a decade ago, or a little over a decade ago, out of a classroom project at Yale University, when we were presented with a challenge statement at the beginning of our semester that 1.5 million children are dying from vaccine-preventable disease. And over the course of the next 15 weeks, we went through a human-centered design process to understand the landscape, to do rapid ideation on possibilities, to address pain points, to then ultimately come up with prototypes, and then take that prototype from the bench to the field. And initially, our focus area when approaching such a large question was the data and accountability aspect behind how immunizations are tracked. And that ultimately led us to developing early digital tools to empower the health worker who is collecting this information, but also to develop a longitudinal record that could stay with the patient, even in remote settings. That's where we had our inception. We partnered with an NGO that was working in Rajasthan, India's largest state. And from the get-go, our backbone has really been public health centered. So we took a digital intervention, which had a component for the health worker, had a component for the patient, and we tested its feasibility. We tested whether or not that digital intervention was actually driving some process and health behavior outcomes. Could we actually improve the quality of counseling? Could we develop a reminder system so that way parents knew when to get their children fully immunized in that first year of life to drive adherence to the immunization schedule? And in all honesty, when we were starting off, we did not have a very large study or a well-powered study to answer that question, but we saw encouraging results. And I would say that the real learnings came from when we were on the ground. But we used those early results to then do a much larger randomized control trial to, again, test whether or not this digital solution could improve infant immunization rates. And this time, instead of working with one NGO, we actually adapted the solution to better align with the national health guidelines that were being practiced by over 50,000 nurses across the country. And that was a much larger study for 2 years, following 3,000 pregnant women and their babies to see how they would get immunized. And what we found is that those pregnant women who were going to these remote health camps in their village, in which the nurse had a tablet device, a digital health app, in which they were also getting these voice call reminders about when to go in for the vaccine. That whole end-to-end digital solution, if they were in a village that had that solution, their children were going to have a 12 percentage point higher rate of finishing their immunization schedule by the first year of life. So that was a really big, encouraging milestone for us to see that rigorous evidence and then take that evidence and say, okay, can we now scale this platform up? So we went to the state health department with that information. And this is when, your journey as a social impact organization can go off on all kinds of tangents, but it kind of comes full circle. So the public health department had its own digital health questions and quandaries at the time. They saw us as an early digital health player that was filling a technical void that other, traditional public health agencies didn't necessarily have the expertise in. Mm-hmm. This is now around 2019, 2020. So they're having us try to now rewire the messy digital health infrastructure of the public health department. And in that process, COVID happens, and we are then asked to develop a system that can help do community-based surveillance at scale across the state. And we had to make a decision in that moment, are we going to focus on maternal and child health, which has been our initial focus, or are we going to move towards primary healthcare? We ended up following the need of the hour, which is expanding our mission. But in doing so, and kind of using that moment as a catalyst, we were able to learn how to dramatically scale up our technology, to go from tablets to smartphones, to go from 100 users to 60,000 users and over the course of 2 months. And these are all community health workers. Mm-hmm. Many of them are using a smartphone for the first time. And through that COVID-based screening process in the community, 14 million people had their health screenings done, which is about 20% of the population. So in essence, that moment was converted into an opportunity in which we can start to do almost a digital health census of the entire state and start to use that information now to help guide other programs. So we took that momentum and then we went to different departments, whether it was the non-communicable disease department or the vector-borne disease department or the TB department. Traditionally, these departments are all working in silos, but now they have a common population base upon which they can do their longitudinal follow-up. So we've taken that approach and kind of sequentially started to partner with other verticals. And Yolanda, now the situation is such that we have solved the data collection problem. Like, we've collected data, health surveys for over 46 million people. We're in a data-rich environment, I would say, but how much of that is being converted into information and insights, and how many of those insights are leading to actions? That's the piece that we're now trying to focus for the upcoming 3 to 5 year period. And the way I like to think about it is completing that feedback loop. So you have the data and information coming in, but how is that going to go back to the community? And I think AI has a huge role to play here. And along the way, we've been tinkering with various different innovations. Largely speaking, AI has a role to play in trying to make sense of big data, to understand patterns and understand which communities are the most vulnerable. When you look at how different data sets stack on top of each other, and how stacking different data sets can help give new information in areas that were previous blind spots. And I think AI also has tremendous potential even at the individual health worker level. We're seeing now within the smartphone, we can use AI for diagnostic value. We can use it as these smartphone applications as screening tools. We can use large language models to help coach and counsel patients. So the situation on the ground is changing dramatically, and AI is going to be an important tool in this overall narrative.
Yeah, I mean, I thank you for that. That's an incredible journey. And I want to get more into the nitty gritty of exactly how AI is supporting your work on the ground. But first, I just want to highlight the progression that you described, from sort of a prototype to a product to really a multi service platform that meets a lot of different challenges. And at the Patrick J. McGovern Foundation, we do believe in the potential of digital technologies and AI to advance health equity. But we also know that success really requires community informed approaches, meaning it's not merely about applying a sort of high tech product to a pervasive societal challenge, but rather it's about identifying a need in partnership with communities, with community health workers, and then taking a critical lens to impact measurement, and then finding opportunities for scale, right? Which I think you've sort of described. And to me, what sets Khushi Baby apart is that you really embody that community informed approach. You don't see the product itself as the outcome, if I'm understanding correctly, but rather it's a means to optimize the human experience of sort of giving and receiving care. So I wonder if you could speak a little more to that. How does this community lens translate to your broader vision for improving healthcare in India?
Yeah, that's a great point. And I'll talk about it in phases. So initially, it was very obvious that we were going to need to work with the community. We're doing a pilot. There's a digital health tool. Public health students that are doing all this mixed methods research. So naturally, it made sense to us that we were going to need to have a field monitoring or a field supervising team that could work with community health workers, collect process data, also support community health workers that were adopting this new technology, and making sure that there was good alignment. And I'm glad that we started off with that initial approach, because that has been a key anchor for us over the years. Things got more complicated when we took that evidence to the state and we were looking to scale up, for a few reasons. One, we don't have a field monitoring that can be everywhere at the same time. So you have to also kind of scale your approach to training, to monitoring, to communication, and using tools like video conferencing or WhatsApp. How can you still stay in touch with the pulse of what's happening on the ground? So that became a challenge. But the other big challenge came up in, now you're in a multi-stakeholder environment. So you have public health officials that have their priorities and their requirements. And that may be, we need to collect information on 800 public health indicators. And maybe the way that the public health programs are designed is that they focus on specific verticals. But those priorities may not be well aligned with the realities that the community health worker on the ground is experiencing. So how do you build a product that both satisfies the requirements of the decision makers, being the health officials, but at the same time accounts for the real experiences of those that are doing the work on the ground? So there is definitely a tension there. And in order to navigate that tension, we realized it would be very important for us to have a team that would both be able to sit at the forest level and see the whole forest, but also work at the tree level, sample the trees, and see what the health of the forest looks like, and have that back and forth dialogue, both top down and bottom up. And I think that is also, as you said, what sets our approach apart from maybe others. We're not coming in at the top level as a consultancy, working with a software house, trying to develop a standard software. We really, in our team, have tried to bring in different disciplines, public health, technology, field implementation, and have that as kind of a continuous learning loop.
Awesome. Yeah, I mean, what speaks to me a lot is, first of all, that you're combining this sort of bottom up, top down approach, which I think is critical because we're trying to align across different stakeholders, like you mentioned. But also, this idea that you actually brought up in the beginning was breaking down silos across different aspects of the public health sector. And I heard this word all the time. In a previous life, when I was working on COVID response, it was silos. Across every part of the world, we see these silos in public health. And creating a tool that sort of meets the different needs of users all at once, I imagine requires a fair amount of testing and iteration, as well as not being afraid to pivot. So let's talk a little bit more about that, particularly in terms of this platform that you've developed. You call it the Community Health Integrated Platform, or if I can call it CHIP for short. Tell us more about how this AI-powered platform works, how it's evolved, and then how you're overcoming some of those multi-user challenges that you just described.
Yeah, absolutely. So the problem statement that we're trying to solve right now is that there are about 12 different health programs, and the reflection of the health program is a digital collection tool. So now you have multiple different apps, portals that are all in play, and the community health worker has to juggle anywhere between 5 and 10 different apps, portals, and spends 50 hours a month on data reporting work. And there are over 1 million village level community health workers in India. So 50 million hours a month are going towards data reporting, juggling these different apps. In many cases, redundant data entry. Like, let's say somebody has diabetes, but they're also pregnant. You have to enter their information into 2 different systems. Those 2 systems don't necessarily talk to each other. So that was the problem statement that we were saying, is that we can streamline this process and we can make it a unified, harmonious experience for the community health worker. So that was the initial idea. And we looked at that, those 800 indicators, we saw 150 of them were redundant that we can get rid of. We can have a common population base, and there are ways for this experience to be more streamlined. And we did that process for all of the key health workers from village up to the district hospital. So, the community mobilizer, the nurse, the primary health, the primary health center team, which includes like a doctor, pharmacist, lab technician. We looked at all of those roles. What are the kind of responsibilities they need, and then how can we make a solution that's relevant for their workflow that looks at not just one health program, but all of primary health in an integrated fashion. So what that means is that we have 2 kind of products that have come out of this. One is an application that is used for planning, for data collection, for clinical decision support, and we have and basically a medical record that works in an offline, lightweight manner. And then we have another tool that is for now health officials, where they can track progress, identify communities that are vulnerable, identify health worker teams that need more support, and ultimately make decisions. And we didn't stop with just having a kind of like a visual dashboard. We really want this dashboard to be kind of an actionable dashboard. And for this, we've incorporated tools in which, from the dashboard itself, you can now do targeted messaging to health worker groups or to patient groups, depending on certain needs that are being identified. So using new channels, WhatsApp, and other means of mass targeted communication, it's one way for us to complete the loop. And now we are also looking, and we've started to incorporate other elements that really now tap into the potential of AI. And that has to do with things like triaging. So at an individual level, how do I figure out if I have 200 patients in my catchment area, which are the 20 that I need to focus on? And maybe the standard rules would tell me that I need to focus on 15 of them, or the standard rules might just say I need to focus on 30 of them without giving me a sense of who's more sick and who's less sick. but actually these are the 20 that I should be focusing on, and this is the order that I should be focusing on. So I would have missed out on 5 of those patients had I just followed the traditional approach. So we have looked at those type of risk triaging statistical models. We've done it especially for child malnutrition, which is an ongoing challenge in India right now, including in the regions that we work. So trying to use data from early pregnancy, throughout pregnancy, to predict what the birth rate will be at the time of birth, at 2 months, 6 months, 12 months. So which are the children that are likely to be malnourished looking forward using the data that we have available. So we've done some of that work. We've also done work on the kind of geospatial side to figure out what are the vulnerable communities, how do I estimate what's happening in this blind spot by adding different layers and combining new types of information together. So one interesting example of this is we take data that comes in from the community health workers about disease distribution. We take other high resolution data that's coming in from Google, for example, on from like Google Maps. How long does it take you to drive from point A to point B? So we calculate how long does it take you to drive from every village to the nearest district hospital in the case of an emergency, for example. And you overlap those two together, you can now figure out, okay, these are the areas where you have high rates of suspected heart disease and you're really far from the hospital. That's a problem. Same thing for an obstetric emergency, for example. So these are the types of new insights that we think that can be unlocked. Another example is in the climate vulnerability space, where we can look at the 3 different seasons being heat stress, vector-borne disease, and then respiratory disease from pollution that kind of happen 3 times during the year. How does that relate with other underlying comorbidities that have been collected by the community health workers? How can we use the community health workers to estimate like the disease prevalence that you don't see at the hospital? Because the hospital is just one point, and you may have a count of how many mosquito-borne or malaria cases or dengue cases are happening at this hospital. Mm-hmm. What about the region around it, right? We don't have any information there. And that's where you use your weather models, you use your community health worker data, you try to stitch it together in a way that gives you a broader picture. And then you use that information to figure out, okay, here's where I need to do my insecticide spraying and my, targeted screenings and therapeutic support. So there are new ways that we're trying to bring data together is kind of the second aspect. And this also goes into this idea that we need to study what actually works. So we really believe that we are in this new big data moment. Data quality is an ongoing concern, but we have now this new incoming large data set from different streams. And really the question is, how can we help together, not just as Khushi Baby, but us, other partners in the government, work together to make sense of that data. So we would like to have this data democratized and used as a public health kind of data bank. And we'd also like to use this data to figure out what works. So can we use CHIP as a measurement tool, in other words? So let's say the government wants to try a new health program or health intervention, or let's say there's a local NGO on the ground that wants to study the impact of some initiative that they're taking. They don't need to now, hire an external agency and do a independent impact evaluation. They can use the existing data to understand whether or not that intervention improved their indicators or not. And this is already starting to be done in a few different examples. The government did this to understand whether or not adding a mid-level provider between the doctor and the nurse, to what extent that helped change healthcare utilization towards government services. And we also similarly used data that had been collected to help adjust the TB program in Rajasthan so that way it was more targeted towards the most vulnerable people that were between 6 and 10 times more likely to have symptoms. So trying to optimize resources by use of the information that's already collected. Mm-hmm. I think the last opportunity that we're excited about now when it comes to AI, and this is still in the R&D bucket, is really now supercharging the application that's in the hands of the community health worker. And how do we we recognize that you may not have a full, ability to run a complete blood count test or have a lab in your backpack, but the phone has a lot of potential. One of the areas that we're really excited about is anemia screening, particularly for pregnant women who are at risk of anemia and its complications both at the time of delivery and for the future kids. Right now, anemia it is a reversible condition, but if you don't detect it, if you don't refer the person, then you're at risk of those complications. So right now, you have to poke someone's finger, draw blood, and either look at a paper strip, which has different grades of red, or put that drop of blood into a point of care machine, which has consumable costs, the test strips, in order to understand what the hemoglobin level is. But the technology is very close, I would say, in the next 1 to 2 years, where we will be able to take a picture of someone's eye, the inner eyelid, and based off the color of that inner eyelid, we'll be able to say, okay, this person's hemoglobin puts them in a moderate anemia range. They should be referred so that they can get an iron transfusion and further workup. So right now, we're actually running the world's largest such study for pregnant women, specifically, to our knowledge, at least in India. We've already completed our phase 1, in which we've enrolled over 2,000 pregnant women, and we have very good results in terms of making that decision of are they moderately anemic or not. And we just got approval over the last few weeks, actually, to scale this up to another 20,000 pregnant women in 2 states. So the idea is that this phone can now itself potentially become a diagnostic device that addresses a real public health need, and that is something that can be acted upon. So that this last piece is crucial. We don't want to your point, when we're thinking about technology that is appropriate for the setting, we don't want to just introduce all the hi-fi technology. We can screen for 100 different conditions, but if we can't actually do something once that person is found positive or negative, then it puts them in limbo, right? So that's not an area that we want to invest our time and resources. We really want to define the problem statement in such a way that it is very much rooted in the community and in the solutions that the community itself can take on. So in this case, the nurse is able to counsel and refer somebody to get an iron transfusion if they need it. Iron transfusion is broadly available. But the way that they're kind of screening and the pre-counseling step is a little bit tedious, expensive, inefficient. And that part we're trying to make smoother with an AI-driven experience. So we're looking for specific problem statements like that meet this sweet spot of not disrupting the process, acknowledging the limitations, and also adding new insight. Because a lot of the things that we talk about, especially in the clinical space, when you think about like risk triaging algorithms and things of that nature, the nurse or even doctor, for the large part, knows who's sick and who's not. But that 5 to 10% where they're not really sure, or it's maybe outside of their domain expertise, that is the kind of sweet spot that we're trying to address with the use of these advanced technologies to help augment and identify that missing slice. So we really have to be careful with how we promise the potential of AI. We really want it to be targeted and focused and aligned with the community's needs.
Yeah, that's great. Thank you for describing all of those different ways that you're using this tool to support the public health operations. But also, I'm seeing sort of on one side, you have it as a sort of analysis, research supporting tool, then it helps decision making, but then it's also used directly in the field by these community health workers, by doctors, by nurses. I want to take a step back because many of us understand the role that doctors play, the role that nurses play. Some of us might not understand the role that community health workers play, specifically in India or around the world. And I want to talk about them specifically. I think you've referred to them as ashas. What does their day-to-day look like? And with a smartphone in hand, with these AI-powered applications in hand, what does it look like then? How has it transformed?
Yeah. So ASHA, the concept of an ASHA started now over 10 years ago, 10, 15 years ago. And it's been a revolutionary model for India. And ASHA stands for Accredited Social Health Activist. It is a female member of their village, their community, that is elected democratically. They are not going to move from village to village because they have been elected after they've kind of settled with their family in that village. And they undergo some basic training on different public health and clinical concepts, but really their role is as a health mobilizer, or health promoter. Their role has now been expanded to cover over 50 different public health promotion activities. But to give you an idea, on a day-to-day basis, they may visit anywhere from 10 to 20 houses. They may go to houses where there's a newborn baby, a pregnant woman that they need to take to the hospital and accompany with them to the hospital. They may be doing a tuberculosis screening. They may be looking for malaria and dengue and collecting blood slides. They do it all. And they're a key linchpin in terms of understanding the health of everyone in their village and getting them to care on time. Unfortunately, from a compensation standpoint, they are getting paid close to or at below minimum wage. And I think this is an area where there's a lot of advocacy happening to boost them up and get them the kind of support that they need. But 10 years ago, Ashas did not have smartphones. Even 5 years ago, there might have been one phone in the household that maybe the husband had, and the husband was off traveling for doing migrant work, and they didn't have access to a phone. Now the situation has changed, at least in India, and in many low and middle income country settings. Smartphone ownership has really dramatically risen to 60, 70, 80%. And even cellular coverage has dramatically expanded so that now smartphones are real tools that many people have access to. So now with the phone in hand, all of the work that they do in terms of screening, following up, figuring out which 10 houses am I supposed to visit today from which programs, all of that falls into their CHIP application or their digital health tool. Policies are still somewhat lagging behind. So they still do need to then copy some of the work onto paper registers. And this is another area where we're trying to advocate and phase out those processes. But it does make their lives easier in terms of having a clear picture of their village's health. And now with AI tools, so I'll give you an example of an AI tool that they're already starting to use in the field right now, which is being powered by large language models. So this was a partnership that we had with Microsoft Research to look at WhatsApp, which is an interface that they already use quite frequently, to develop a chatbot that uses OpenAI's APIs and also combines that with the ASHA's own public health curriculum. So they have various different PDFs, chapters that they need to know about. So can we make a bespoke large language model solution, chatbot solution for them that answers questions at the level of the learner and is available 24/7? They would tell us that there was stigma in asking questions to some of their supervisors or not being able to ask questions at any time of the day. And this tool gave them the freedom to ask those questions. And not only does it answer the question, it allows them to ask the question with a voice note in Hindi, the local language. It also responds with both a text response as well as a voice response. They can then play that voice response out loud on the speaker and use that to aid in their counseling. So for example, I remember one Asha was telling us about how she was trying to explain the side effects and risk benefit profile of a long-acting contraception injection. And she wasn't quite sure of all the details. She asked this question. She played the voice recording out in front of the beneficiaries that she was visiting, and that helped kind of bridge the communication gap and aided in her counseling. So this is really an exciting opportunity for knowledge to be so accessible and so user-friendly. And many people are working on now seeing how we can supercharge this interface and use large language models. For the large part, large language models from a medical standpoint are very, very, very good. Papers are now coming out. AI alone is better than AI plus doctor. They're acing all the medical exams. I think the area where these large language models still need to improve upon is in understanding the local language and context. So either if it's a specific dialect, if it's a specific health policy that is really relevant for that area, it may not have all of those details. And that's where having a team that's working closely with the community can help tailor it to meet the needs. But we're very much excited. I mean, I think that information is going to be accessible to everyone, and it doesn't have to be through WhatsApp. It can be through Gemini's Google Assistant, or they can download the free OpenAI app. And they can use whichever modality they want. The question is, how do we learn from the questions that they're asking to better think about supporting the public health program? So that's one way that we are trying to approach it. How can we also use this interface for two-way communication? So not just they're asking a question once in a while, but we use this as a way to also let them know about the performance of their catchment area. So that way it's a little bit more personalized and relevant for them. And how do you do this whole thing in a way that, of course, protects data privacy, that, ensures that, we're adhering to best practices. So it's an exciting time, and technology is moving very fast. It's becoming very hard to even study what the effects will be. I think for us, we just need to understand that the cat is out of the bag, and we need to figure out how we can tailor it in a way that's productive.
Yeah, that's fascinating. I appreciate that you brought up some of those challenges like data privacy. I was actually going to ask about if you ever experienced any challenges like hallucination, bias early on, and how you overcame those. But on a broader level, I also want to talk about something that I think you're speaking to, which is very connected to the values we have here at PJMF, which is the importance of human-centered design. And I wonder, on top of sort of overcoming some of those challenges, infusing best practices into the design, how have you infused human-centered principles into your creation of CHIP?
Yeah, so I think it really starts with having a field team as a core part of our team. So even from our early days, we had 12 field monitors. Now the number has gone up to, because in each state we have about 10 to 12 field monitors, so the number has expanded. But the role of the field monitor is to they're from the communities where the solutions are deployed. So they work there 5 to 6 days out of the week. They are working hand in hand with the community health workers. They understand the pain points of the solutions in real time. So they're providing some training capacity support, but they're also collecting information that allows us as a team to refine the product to better align, and also to better advocate, right? So we're able to make our product that we think addresses a pain point, but there may be a policy or some other structural barrier for that product to realize its potential. Having eyes on the ground allows us to then also inform our advocacy approach. And working with the public health department, that advocacy is also a central piece to what we do. I think it's also allowed us to hone in on the problem statement and figure out like what is, too futuristic and, too much of a technology-driven approach, and allow us to pause and say, okay, what is a more human-centered approach, right? So if you don't have that team on the ground and that element, because the technology is out there, right? We can do fancy analytics, make very advanced statistical models, and then you present that to the health official, and if the health official is just looking for some basic exploratory summary stats about what areas are red, what areas are green, it's like you're talking two different languages, right? So you need to find a way to sit with the end user, to understand where they're at, to meet their need, to meet their immediate pain point, and then yes, over time you can try to work towards some kind of joint future in which there maybe might be some more intermediate analytics, for example, in the case of the dashboard, or you can slowly take them on this journey towards more actionable insights, right? So the fanciest technology is not always the right technology, and it may assume a lot of things about the quality of data and whether or not that data can even be acted upon. So really, it's about, I think, defining the right problem statement. So like I said with the anemia example, or like I said, or like I mentioned with this example of Asha's needing to look up information and wanting some support in how they counsel. And I think there are other examples of that. We have another project right now that is yet to kick off, but is in the planning stages, in which we're trying to take AI solutions that have been developed at the Yale Cardiology Data Science Lab that are state-of-the-art solutions for predicting heart disease. Without you just need to look at the electrocardiogram, the ECG. You don't need to do an ultrasound or echocardiogram of the heart. But just by using that electrical signal, which you need a device about this size and you put your fingers on it, you can predict how the heart is squeezing. So we're really interested in seeing how can we plug this technology into the chip platform and study whether or not it's useful, because if the heart is weak, there are different drugs that you would give than if somebody just had high blood pressure. And in India, the access to ultrasound to look at the heart is very limited for a variety of different reasons. So could this be a moment in which the technology, this small, relatively inexpensive device for ECGs, this AI, and then the platform that gives the clinical decision support, that also triggers the follow-up in the community with the ASHA workers, that whole digital solution, can we merge these together in a way that will lead to earlier identification of patients that have heart problems and get them on the right treatment earlier? So we're trying to find the right question that is kind of on the edge of what's possible, but still very much considers the resource constraints that we're operating within.
Yeah. That's also fascinating. I feel like I'm getting a crash course on medicine and public health at the same time, which is great. So thank you for that. I think we're getting some questions in the chat, and I will get to those shortly. But before I do, I want to talk about something, kind of a theme that I'm hearing pop up, which I think is probably very important in the work you do, and that's trust. The fact that you keep sitting with the end user, you're making sure that you're asking the right questions, you're making sure that you're meeting the needs. And I imagine that trust is something that's affected deeply by how effective or useful a tool is perceived to be. So I wonder, how do you measure effectiveness and impact, and what does that look like to you?
Yeah, no, it's a really key question. Like, I don't want to pretend that everything that we've done has been all roses. We've had lots of struggles. Technology can fail. We learn. We try to learn and make improvements so that way we don't repeat the same mistakes as we go along. And certainly as we scale, we've made lots of missteps. And along the way, yeah, trust has been impacted. And I think really, in order to build trust over time, you need to show consistency. You need to show that you are truly in partnership, that you're there to stay, that you're not just here to start a pilot, dump a solution, and get some credit and leave. You're actually there to stay and shape the way that the health system performs in the long run, right? So that's been our ethos from the beginning. I think that with new technology, there is healthy skepticism, and we also need to be skeptics of the technology that we are pushing, whether it's large language models or narrow AI. We have to ask ourselves, what is the additional value that we are actually providing? If we give this information, are users actually going to use it, or is this just another kind of cool feature that we get excited about that doesn't change the underlying conditions in which health workers are working in? So having that recognition is also important, and that goes back to being rooted in the community, having the right advocacy channels as well. How we measure impact, and we see impact as a spectrum or like different stages of maturity. So ultimately, what we are trying to do is we're trying to rewire the digital health infrastructure so that way the feedback loops are more connected, and that people are using data for action at all levels in the public health system. So the stages of maturity are: do you have a digital health system that can collect and process data effectively and at scale? That's the first kind of step, which I would say is like adoption, and how easy of a user experience is it for those who are involved. The next step, which we are currently in, is how have we used that data to now identify diseases, disparities? How have we connected that data to different programs, health officials, health workers, connected it to call center teams to do outreach proactively? So that way the information is now being acted upon to both identify areas of need and start to respond to areas of need. And then the last piece, when we talk about, okay, impact is now being achieved, that requires different indicators to change. That means that the health system needs to get better at delivering care to the areas that are more cut off. Health behaviors on the part of patients, you would like to see those improve, right? So you'd like to see patients that were high risk, that were identified in stage 2, actually get to their referral checkup, get the treatment that they need, get started on the treatment that you identified was like this, the system identified would be important for them. And then last but not least, after all of that happens, after you treat pregnant women that have anemia or patients that have TB, then yes, of course, the final health outcomes of, mortality, morbidity would be measured. But those are still things that will be, well in the future, and it'll be hard to attribute whether or not digital health system alone really had an impact that downstream. But yes, on the process level indicators, we will be able to have better attribution. And the final stage of this is, again, going back to thinking about CHIP as a measurement tool. So what along this process worked? It's not how much did, the digital health platform improve the treatment of anemia from, 20% to 25%. What were the conditions that made the platform more successful? That's also a really important question. And what other interventions, maybe it was a new health campaign or some other initiative taken on by somebody on the ground, a local NGO, which of those interventions and what mix of interventions actually drove that change up? So there are, statistical ways that you can now look at using the dashboard to set up randomized controlled trials or A/B tests, and figure out, okay, which of your public health intervention strategies is actually driving the change that you see. Once you find something that is driving change, then to highlight that and then say that this is an evidence-based strategy so it can be replicated in other areas that are similar. So once you get to impact, identifying what worked and replicating that would be the kind of final part of the puzzle.
Yeah, it's interesting. It seems that, and very much so, I think AI can be a tool to really reshape and strengthen broken health systems, overwhelmed health systems, to really be fit for purpose in a sense, because I feel like we're coming into an era where we're dealing with a lot of intersecting challenges. You mentioned climate and how that impacts health, and public health systems need to be prepared to respond. And I'm glad that you're using AI in a way that actually explores how all public health systems can sort of stand up to that challenge. One of the questions in the chat that I think is interesting from Jacqueline is, has this AI-powered public health tool been considered for adaptation or testing in other countries? Do you have any insights on cost considerations?
Yeah, so I think many organizations are working from different countries and kind of converging on similar solutions. So if we look at the large language model space, or even if you look at the anemia detection space, it's interesting to see that, different resource constrained environments may have this kind of convergent evolution pathway. From our perspective, what we are trying to do is, India is quite diverse and vast as it is. Each state is like a country. For the models that we find that work, we'd like to publish this, in the peer-reviewed research community. We'd like to make sure that our model, we can have kind of open source data to the extent that it's anonymized, open source models, So that way others can use their data, use existing kind of foundational models, and fine tune the models based off the local conditions. So that would be an ideal result for us, because we also recognize that our team can't be everywhere. We're in particular looking at how we can make our anemia work follow this pathway. And some of the standards have already been set out by organizations like Google that have models for screening for TB by listening to the voice. They have also kind of taken this approach where they have a foundational model, and now others can use their own training data locally to fine tune it as per their needs.
I imagine that ability to sort of fine tune local data to like the local context helps with the issue of bias. There's actually another question in the chat that talks about whether you've observed any bias or ethical concerns given the diversity of the geographies that you've covered and the vulnerabilities of some of the communities.
Yeah, I think that it is, when we talk about doing studies in communities that are vulnerable, that have low levels of literacy, we need to recognize that what we think about as informed consent, for example, as a concept, even during routine data collection, may not actually be happening the way that at the standard that we would like, right? The best kind of compromise that we can have is to rely upon the ASHAs and the trusted health workers in the village to be the brokers of this new technology. And that's why it's so important to partner with them. So if they themselves are finding value with it, they are in touch with the community, they can help broker that relationship and convey some of that information, then you would hope that it pushes you towards more informed consent. But in many times, in a lot of the research, I mean, we're also not perfect at this by any means. Do the people that sign up for the research studies on different AI tools, do they know what's happening with their data? Do they know how that data is going to live in perpetuity, or how it may be used? Do they know how to revoke the data access after the research is completed or after it's been collected? The answer is most likely not. The data is collected and it goes into some black box. And I think it's the responsibility of those that are working in the space, researchers and implementers, to try our best to make locally relevant materials and to train the local teams to convey the impact of what this data could mean. Of course, this seems like a higher level problem. Like we of course need to ensure that these communities are getting the basics first, right? They're getting the basics when it comes to like availability of health workers and health facilities and drugs and supplies, and that we're not overlooking those things when we're focusing on this data privacy and those types of concerns. But yes, we do need to be very thoughtful about it, and I think working with the local communities is the best way to do that.
Yeah. And I think you've done that in quite a exemplary way. Given sort of all your experience, there's another question in the chat, which I think you'd have some great insights on. Do you have any suggested language for organizations that are hesitant or even fearful of engaging with AI?
So I would say that it's all around us now, right? I mean, we use different, many of us are now using, you do a Google search, like it's there, right? You can't get away from it. So AI tools are going to be more and more available. We're going to use them in our own workflows, and certainly they're going to help accelerate certain things that previously organizations may not have had familiarity or skill sets with. I do think that there's an opportunity, a huge opportunity for learning and capacity building in this space about how can we effectively use AI tools? What are their limitations? What is the ethics around AI? And I think that we as a community need to talk more about that and make it more accessible for organizations that may not be as familiar, because it is a very rapidly evolving space. And it's hard to keep up with all the changes that are happening.
Yeah, those are all really great points. And I'll add that the Patrick J. McGovern Foundation has a resource called the Learning Hub, which provides a lot of support to organizations that are at various stages of their AI journey. And it does include, of course, language that can be used to speak to different users and communities that may not be as comfortable with AI starting out, but want to embark on that journey. So be sure to check that out. Rishit, this has been wonderful. I have sort of a couple of closing questions for you. One, how can the audience stay up to date and informed on your work? But more importantly, I like to end every conversation with an opportunity for you to bring out your visionary side. Think about what are some of the future directions, maybe 5, 10, 15 years down the road that you're hoping to see in AI-powered healthcare?
Yeah. So you can follow us on LinkedIn. So thanks to LinkedIn for this platform and opportunity. That's where we have most of our updates. And on KhushiBaby.org, we'll have our annual report will be coming out soon. But yeah, I mean, to your last question, and I'll also quickly plug, we are looking for the best, most talented people in the world to come join us. We have a 120-person team, and it's very interdisciplinary: public health people, technology people, data science people, field people, all working together. So, if any of the work or anything that we talked about today interests you and excites you, we want you to come work for, really hard, impactful problems. And we hope that you can come join us. But to kind of sell you on the vision moving forward, and the promise of AI, I think, I really don't know what the next 5 years will look like especially, the generative AI boom has really been quite transformative. Some areas that we are looking into now in kind of that horizon, one is is on the agentic side. So having an agent that works as a data analyst for health officials, for example. So 5 years from now, there won't really need to be a public health dashboard. I mean, I don't know. There's a running joke that people don't really use dashboards after they're built, but you could imagine an agent that proactively analyzes data, surfaces relevant insights. You could talk to them in natural language. And some of this stuff is already possible. Like we have an internal tool that we can talk with natural language and get some basic data back and forth. But I'm talking about a 24/7 public health data analyst, for example, that can look at big data sets and not get confused. Right now, that capability doesn't exist, but I would anticipate in the coming years that might be a possibility. And then the other is more on the aspect of community outreach. So although, yes, we're collecting lots of data from community health workers right now, the data is of varied quality. And there is a need to kind of double check and do quality assurance on the data that comes in. And for this, you have to speak to, people, to the actual patients or beneficiaries themselves. How do you do that at scale? Well, you can't scale up your call center to the whole country, but now these, again, we're not there yet, but you could imagine a situation in which instead of a sales team having a agent call center, you have a public health call center. And what would that look like? And how could that be leveraged to collect information, to kind of encourage and counsel patients to go for referral visits, and to, qualify the data that's coming in from community health workers, not to replace any of their efforts, but to add another layer of texture to the data that's coming in. So those are some areas I think that hopefully we will also be able to streamline some of the underlying data collection challenges that we have. Hopefully we'll get rid of paper. Hopefully health workers will be able to spend more time on giving care or spending time with their own families, as opposed to collecting a bunch of data, and not all of that data is important. So that's the future that I'm looking forward to. And I finally hope that we'll be able to share data more democratically for research, for organizations to use. And I think, the biobank concept has been very successful. But when you come to low and middle income country settings, we don't have a parallel concept. And that's something that I think in the next few years is certainly possible. We just need to have the right community approach, the right advocacy, government involvement as well.
Awesome. Well, this has been such a rich and engaging discussion. We've talked about the ways that your team is leveraging AI to really understand health worker needs and make their jobs easier. We've talked about the challenges of meeting different stakeholder priorities and sort of balancing those priorities. And we've talked about the journey to scale, which is really incredible how Khushi Baby has taken that journey itself, one that's grounded in a commitment to humility and human-centered service. So thank you again, Rushith, for taking the time to join us today. And thank you to our audience as well. We really appreciate you all tuning in, and we look forward to seeing you next time. Bye, everyone.
Thanks so much.